In this video, I'm going to look at a group of drugs called the sympatholytics. This video will be first in a line looking at antihypertensive pharmacology, of which the sympatholytic drugs, and most importantly the adrenoceptor antagonists, are but one class. Let's begin by breaking down this word a bit. We have the sympath bit, that refers to the sympathetic nervous system, and we have the lytic bit, that means breaking down or stopping. So really, the term sympatholytic just refers to any agent that stops the effects of the sympathetic nervous system and calms down or reduces the body's own stress responses. Sympatholytic drugs are used to treat a variety of clinical disorders, usually caused by excessive sympathetic stimulation, but are most commonly known for their antihypertensive and anti-anginal properties. We can split the sympatholytic drugs up firstly into three categories based on their mode of action, or we can say by their pharmacodynamics. Blocking of the sympathetic nervous system can be achieved in three ways, either by using ganglionic blocking drugs, such as trimethophan, which really are quite rare and are only really used in hypertensive emergencies, so I won't really dwell on these too much. We could also use sympathetic neuronal blocking agents, such as the antihypertensive drug receptor, which nowadays tends to be outclassed by much safer and more effective agents. And lastly, we can use the class that are most commonly used, and therefore the ones I'm going to focus on in this video, the adrenoceptor antagonists. So let's now look at the adrenoceptor antagonists in more detail. This class of drugs, which are also sometimes called the adrenoceptor blockers, are broken down into subcategories based on their specificity, just like the sympathomimetics were in the last video. We can divide them up into those agents that target alpha adrenoceptors only, so alpha blockers, or those that specifically block the beta adrenoceptors, the beta blockers. This can be extended to classifying the drug we're looking at based on whether it blocks alpha 1, alpha 2, or beta 1 or beta 2 adrenoceptors. There are additionally drugs that block a mixture of alpha adrenoceptors or a mix of beta adrenoceptors, as well as those that don't differentiate at all and target both alpha and beta adrenoceptors. We would therefore classify this last type as non-selective adrenoceptor antagonists. An example of this would be carvedilol, a drug which is used in the treatment of congestive heart failure. To give an example to summarise this, we can say that the non-selective alpha blockers are less effective at decreasing vascular peripheral resistance due to the indirect stimulation of alpha 2 receptors, attenuating the effects of alpha 1 receptors. We can also classify adrenoceptor blockers based on whether they act competitively or non-competitively to block the sympathetic nervous system from reducing the stress response. Non-competitive agents greatly increase the physiological effects by tending to possess longer half-lives. In general, though, we can say that most of the intended therapeutic effects for really whichever disease we're looking at tends to come from the selective blocking of alpha 1 and beta 1 adrenoceptors, with most of the unwanted effects coming from the stimulation of the receptors that were not originally intended to be blocked, and this is typically the alpha 2 and beta 2 adrenoceptors. Let's now take a look at alpha adrenoceptor blockers. As a recap from the last video, stimulation of alpha adrenoceptors leads to relaxation of vascular and other smooth muscles, such as in the urinary tract, by specifically blocking endogenous catecholamine molecules, such as adrenaline and noradrenaline, from binding to alpha adrenoceptors. Selective alpha 1 antagonists are most commonly seen drugs of the alpha blockers, being primarily used in the management of hypertension. They are also, however, used in other conditions, being indicated for the treatment of urinary obstruction secondary to benign prostatic hyperplasia. That is, typically an age-related thickening of smooth muscle in the prostate. Let's look at a couple of examples of alpha blockers and study their mechanism of action to see how they can be useful in clinical situations. The first drug I want to look at is doxazosine. Doxazosine is classed as a selective alpha 1 adrenoceptor blocker that can be used to treat primary hypertension, that is, high blood pressure without a specific cause. Doxazosine acts competitively, blocking alpha adrenoceptors present on vascular smooth muscle. So in terms of pharmacodynamics, doxazosine competes with endogenous catecholamine molecules, and this is for the alpha 1 adrenoceptor, present on either vascular smooth muscle, as well as being present on the muscles of the urinary tract, with the prostate gland particularly being affected. The overall effects of the drug, therefore, are to cause a smooth muscle relaxation in the peripheral vasculature, but also within the urinary tract. In blood vessels, this leads to vasodilation, a decrease in total peripheral resistance, and therefore a decrease in blood pressure. In the urinary tract, this eases the symptoms of urinary obstruction, especially when it's caused by a benign prostatic hyperplasia. So in terms of its pharmacokinetics, doxazosine is administered as an oral preparation, and this is acceptable as it is roughly 65% bioavailable, and this is due to variable first-pass hepatic metabolism. After absorption in the GI tract, doxazosine is highly bound to plasma proteins at 98%, and this does make sense given its bioavailability level I mentioned before. In terms of dose, a 1 mg prescription of the drug is indicated for hypertension, and this is given once daily. This is, however, just a guide value, and for many patients, a titrated dose is usually required due to the development of adverse drug reactions. So the predictable adverse drug reactions include hypotension, dizziness and sedation, and this is due to excessive vasodilation and CNS depression, brought about by adrenoceptor blockade. Doxazosine tends to produce more side effects than the newer, third-generation uroselective alpha-1 blockers, but this is expected, as is the nature of the drug refinement process. So let me bring up a quick sketch to get a visual idea of how this drug exerts its pharmacologic effect. So here is an alpha-1 adrenoceptor sitting on the cell surface of a smooth muscle cell. The pink molecule is one of our body's catecholamine molecules, so maybe we can say that this is noradrenaline. The red circle is our alpha blocker, doxazosine. So in this situation, what doxazosine does is it binds to the adrenoceptor instead of adrenaline, competing for the space. The difference between doxazosine and noradrenaline is that doxazosine does not produce the physiological effects that underpin the stress response. The net effect of doxazosine binding instead of noradrenaline is smooth muscle relaxation and vasodilation, leading to a decrease in total peripheral resistance that subsequently lowers blood pressure. Delving into the history of alpha blockers for a minute, much of the founding literature was undertaken by the pharmaceutical organisations who made the first agents, and in comparison with beta blockers, subsequent research to precisely understand its pharmacodynamics in light of some newer research methods, have been overall less extensive. It is therefore difficult to state explicitly that the specific competitive inhibition ability of alpha blockers that I propose is entirely valid. This is the literature is comparatively sparser than it is for beta blockers, and I'll discuss this further later on in the video. So let's move on to looking at the drugs used specifically to target the beta adrenoceptor. As a review, stimulation of beta receptors tends to increase cardiac output, raise blood pressure, and cause bronchodilation, among many other physiological effects. In terms of sympatholytic pharmacology, drugs exist that are selective for the beta-1 adrenoceptor, as well as some being non-specific in their pharmacodynamics. An example of this is carvedilol. Beta adrenoceptor antagonists, or blockers as they're commonly termed, are used in the treatment of stress-related pathologies such as hypertension, angina pectoris, and heart failure. Early drug examples tended to be mixed beta-1 and beta-2 blockers and had a high side effect profile. An example of this is propranolol. Newer generations of drugs, examples which include Atenolol and bisoprolol, tend to be more cardioselective in their effects, blocking the effects of catecholamines on beta-1 receptors in the heart, and therefore avoid the adverse effects associated with beta-2 receptor blockade, such as bronchospasm and hypoglycemia. Blockade of beta-1 adrenoceptors causes a reduction of the sympathetic stimulation to the heart, acting at the sinoatrial node, atrioventricular node, and myocardium itself. This selectivity for the beta-1 receptor occurs best at lower doses, as at higher doses this selectivity greatly reduces, and beta-2 blocking effects can also occur. This is the reason why beta blockers are avoided in patients with asthma, and is partly responsible for why beta blockers are avoided in diabetes patients if at all possible. Some beta blockers additionally possess a quality called intrinsic sympathomimetic ability, or ISA, Essentially, this property is where a drug, in addition to its sympatholytic properties, can bind to and stimulate adrenoceptors in cardiac tissue. Now, this may seem a bit strange, especially given that the clinical conditions treated by beta blockers, that I outlined before, are usually, at least in some part, caused by overstimulation of the sympathetic nervous system. So why are these agents used? Well, the main reason is to reduce side effects. These agents, and an example is acetabutalol, tend to produce less reflex bradycardia whilst concurrently maintaining their sympatholytic abilities. This has reduced the overall incidence of the dose-dependent adverse drug reactions that occur from adrenoceptor blockade, and exemplifies the positive outcomes that can occur with continual drug research and development. Let's now look at an example of a beta blocker to show some clinical relevance. Let's discuss Atenolol. Atenolol is a selective beta-1 adrenoceptor antagonist and is used broadly in the treatment of angina, hypertension, acute myocardial infarction, and other cardiac disorders. So in terms of pharmacodynamics, Atenolol selectively blocks the stimulation of beta-1 adrenoceptors in cardiac and renal tissue, amongst others. It is particularly good at preventing exercise-induced tachycardia in susceptible individuals by suppression of sinoatrial and atrioventricular node activity. It therefore can also be used as an effective anti-anginal drug, but I'll talk a bit more about this in the next video. Atenolol's mode of action in hypertension is not entirely understood, and is hypothesized to occur from either a suppression of renin production, as beta-1 adrenoceptors are also present on renal juxtaglomerular cells, a direct sympatholytic effect on the heart, leading to a reduction in cardiac output, or from a central or CNS effect. Atenolol possesses little intrinsic sympathomimetic ability, and therefore has a reduced CNS stimulation effect compared with similar agents, and leads to fewer side effects, such as reflex tachycardia and vivid dreams. However, beta-2 blockade does increase with higher dosages, and this is the main reason it is cautioned with individuals with concomitant asthma, due to the increased risk of bronchospasm. So in terms of pharmacokinetics, the drug is typically prescribed as an oral tablet, but can also be administered parenterally. It has a 50% absorption in the GI tract, but it is said to possess less variability than other similar drugs. Its peak antihypertensive effect occurs at 3 to 4 hours post-administration and has an elimination half-life of approximately 6 to 7 hours. Interestingly, the excreted drug is largely unchanged in the urine, suggesting minimal second-pass metabolism. Predictable, dose-related adverse drug reactions occur due to excessive blockade of the sympathetic nervous system and include reflex bradycardia and heart block. Persistent cold extremities is another reported side effect, and therefore it makes sense that the drug is considered inappropriate prescription in patients with concomitant vasospastic disorders, such as Raynaud's phenomenon. This video has been a brief introduction to sympatholytic pharmacology. Sympatholytics fall into 3 classes, with the most important branch concerning adrenoceptor antagonists. The primary function of these classes is to antagonize the sympathetic nervous system and decrease the stress responses. Adrenoceptor antagonists, commonly referred to as the blocking agents, can be subdivided into those agents specifically blocking alpha adrenoceptors and those specifically blocking beta adrenoceptors. Selective alpha-1 adrenoceptor blockers are chiefly used in the management of primary hypertension and urinary obstruction secondary to benign prostatic hyperplasia. An example of this is doxazosine. Drugs selected for the alpha-2 receptors are used in the treatment of secondary hypertension and include phenoxybenzamine. Selective beta-1 adrenoceptor blockers are used in the treatment of hypertension, angina pectoris, cardiac arrhythmias, and acute myocardial infarction. Examples of these agents include Atenolol and acetabutalol. Mixed or non-specific adrenoceptor blockers also exist and are used in the treatment of cardiac failure. A common example is carvedilol. The antihypertensive pharmacodynamics of selective beta-1 adrenoceptor blockers are uncertain. In the next video, I'm going to look at vasodilator and anti-anginal pharmacology. I'll take a look at the pharmacodynamics and pharmacokinetics of the common drugs of this class, and take a look at the adverse drug reactions and the relevance to clinical practice. I will then go on to describe the overall pharmacologic management of angina pectoris.